Hello everyone. So today we are going to mostly read about intrapartum care for positive childbirth experience given by WHO. And in this video, we will be mostly revising all those management of labor, various stages of labor. We have already discussed it on our previous video. We are just talking it again in the form of summary. And this intrapartum care for positive childbirth experience given by WHO. So, what are the intrapartum care for positive childbirth experience? There are various options, care option, and that is recommended status by WHO. And for talking about care throughout the labor and birth, first of all, we have the respectful maternity care, and the childbirth experience should be made respectful. The care is provided to all women that maintains its dignity, privacy, and confidentiality. It also ensures the freedom for harm and mistreatment and enables the informed choice, continuous support during labor and childbirth, and this is recommended by WHO. And next one is effective communication. Effective communication between maternity care provider and women in the labor using simple and culturally acceptable model is recommended. And the companionship, a companion of choice for all women throughout the labor and childbirth is recommended. Companion of choice, and this is recommended. And continuity of the care, the midwife lead continuity of care model. The midwife lead continuity of care model, in which non-midwife or a small group of midwives support a woman throughout the antenatal, intrapartum, and postnatal continuum are recommended in the settings with the well-functioning midwifery program. And this is specific recommendation, and this might not be possible in all the scenario. And next we have the first stage of labor. The various we have to do various care, like definition of the latent and active first stage of labor. The use of the following definition of the latent and active first stage of labor is recommended. The latent first stage is the period of time characterized by the painful uterine contraction and the variable changes in the cervix, including some degree of effacement and slower progression of dilation up to 5 cm. This data is important. Up to 5 cm of dilatation of the cervix for the first and subsequent labor. And the active first stage is period of time characterized by the regular painful uterine contraction of substantial degree of cervical effacement and more rapid cervical dilatation from 5 cm until full dilatation for the first and subsequent labor. Next, in the duration of first stage of labor, the woman should be informed that a standard duration of latent first stage can vary widely from one woman to another. However, the duration of active first stage from 5 cm until full dilatation usually does not extend beyond 12 hours, and in the first labor and the 10 hours in subsequent labor. And this is recommended. 12 and 10. The active stage does not extend beyond 12 hours in first labor and 10 hours in subsequent labor. In the primary gravity, it is 12 hours, and multipara, this is 10 hours. The progress of first stage of labor, the labor may not naturally accelerate until the cervical dilatation threshold of 5 cm is reached. Therefore, the use of the medical intervention to accelerate labor and the birth, such as oxytocin augmentation or cesarean section before this threshold, is not recommended, and provided that the fetal and maternal condition are reassuring. So progress of the first stages of labor is not augmentation is not recommended, and the clinical pelvimetry on admission is not recommended. The routine clinical pelvimetry on admission in labor is not recommended for healthy pregnant women. For healthy pregnant women, it is not recommended. And the routine assessment of fetal well-being of the labor on labor admission, auscultation using the Doppler ultrasonic device or PNAD fetal stethoscope is recommended for the assessment of fetal well-being on labor admission. And the perinatal or pubic shaving, the routine perineal or pubic shaving prior to vaginal birth is not recommended. And the enema on admission, the administration of enema for reducing the use of labor augmentation is not recommended. Again, and digital vaginal examination, the digital vaginal examination at the interval of 4 hours is recommended for routine assessment of active first stage of labor in low risk women. And the continuous cardiotocography during labor, continuous cardiotocography is not recommended for assessment of fetal well-being in the healthy pregnant women undergoing spontaneous labor. This is not recommended. continuous cardiography in the healthy pregnant women undergoing spontaneous labor. And the intermittent fetal heart rate auscultation. The intermittent auscultation of the fetal heart rate with either Doppler device or pinard fetal stethoscope is recommended for healthy pregnant women in labor. And the epidural analgesia for pain relief. Epidural analgesia recommended. This is recommended for healthy women requesting pain relief. Women requesting pain relief during labor, and this depends on women's preference. This is as for women. And the opioid analgesia for pain relief. The parenteral opioids such as fentanyl, dimorphine, and pethidine are recommended option for healthy pregnant women requesting for pain relief during labor, and this depends on women refer. Same as that of epidural analgesia. And relaxation technique for pain management. Relaxation techniques such as progressive muscle relaxation, breathing, deep breathing exercise, the music, mindfulness, and other various psychological techniques, psychotherapeutic techniques are recommended for healthy pregnant women requesting pain relief during the labor. This depends on women preference. And the manual technique for pain management. Manual techniques such as massage or application of warm pack are recommended for healthy women, pregnant women requesting pain relief during labor, and this also depends on women preference. This is all according to the woman's preference, and this is not mandatory to provide this analgesia and relaxation and manual techniques for pain management. And oral fluid and fluid. The women with low risk oral fluid and fluid intake during labor are recommended for low risk women. And maternal and morbidity and position. Encouraging the adoption of mobility and upright position during labor in women at low risk is recommended. Mobility and upright position. And the early amniotomy and oxytocin. The use of early amniotomy with early oxytocin augmentation for prevention of delay in the labor is not recommended. Early amniotomy and oxytocin is not recommended. And antispasmodic agent. The use of antispasmodic agent for prevention of delay, prevention of labor is not recommended. And now talking about intrapartum care in the second stage of labor. The definition and duration of the second stage of labor is that the use of following definition and duration of second stage of labor is recommended for practice. Second stage is the period of time between full cervical dilatation and the birth of baby, during which woman has involuntarily urge to bear down as a result of expulsive uterine contraction. And women should be informed that the duration of the second stage varies one woman to another. And in the first labor, birth is usually completed within 3 hours, whereas in subsequent labor, the birth is usually completed within 2 hours. The birth position for women with or without epidural. For the woman with or without epidural analgesia, encouraging the adoption of birth position of the woman individual choice, including upright position, is recommended. Adoption of birth position of individual woman choice. And the method of pushing in a woman in the expulsive phase of second stage of labor should be encouraged and supported to follow their own urge to push, and this is recommended. And the in technique for preventing perineal trauma for women in the second stage of labor. Technique to reduce perineal trauma and facilitate the spontaneous birth, including perineal massage, warm compresses, and hands-on guarding of the perineum are recommended based on the woman's preference and option available to her. And episiotomy policy. The routine or liberal use of episiotomy is not recommended. This is not recommended, routine use of episiotomy for the women undergoing spontaneous vaginal birth. And the fundal pressure. Application of manual fundal pressure to facilitate childbirth during second stage of labor is not recommended. Now we have the third stage of labor. The prophylactic uterotonic. The use of the uterotonic for prevention of postpartum hemorrhage during the third stage of labor is recommended on all women. Use of uterotonics for the prevention of PPS. And the oxytocin is a recommended uterotonic drug for the prevention of postpartum hemorrhage. Oxytocin 10 international unit, intramuscular or IV. And instead, in the setting where the oxytocin is unavailable, use of other injectable uterotonic if appropriate, ergometrin or methyl ergometrin, or the fixed drug combination of oxytocin and ergometrin, or oral misoprostol or 600 microgram is recommended. And delayed cord clamping. The delayed cord clamping not earlier than 1 minute after birth is recommended for improved maternal and infant health and nutrition outcome. And controlled cord traction in the setting where skilled birth attendants are available, controlled cord traction is recommended. And the uterine massage. The sustained uterine massage is not recommended as an intervention to prevent postpartum hemorrhage in the women who have received the prophylactic and oxytocin. Care of newborn. The routine nasal or oral suctioning of the mouth and nose should not be performed in the case of neonate born through the clear amniotic fluid who start breathing on their own after birth, and this is not recommended. Suctioning is not recommended. Where the neonate who has been born through a clear amniotic field and we start breathing on their own. And the skin to skin contact, newborn without complications should be kept in skin to skin contact with their mothers during the first hour after birth to prevent hypothermia and promote breastfeeding, and this is recommended. And the breastfeeding, all newborn including low birth baby weight we are able to breastfeed should be put into breast as soon as possible after birth when they are born clinically stable and the mother and baby are ready, and this is also recommended. And the care of women after birth, uterine tonus assessment, postpartum abdominal uterine tonus assessment for early identification of uterine atony is recommended for all women. And the routine postpartum maternal assessment, like all postpartum women should have regular assessment of vaginal bleeding, uterine contraction, fundal height, temperature and heart rate pulse routinely during the first 24 hours starting from the first hour after birth, and the blood pressure should be measured shortly after birth. If normal, the second blood pressure measurement should be taken within 6 hours, and the urine void should be documented within 6 hours, and this is recommended. And discharge following uncomplicated vaginal birth. After an uncomplicated vaginal birth in a healthcare facility, healthy mother and newborn should be receive care in the facility for at least 24-hour birth, and this is recommended. So this is as per WHO recommendation from 2020. So that was all about intrapartum care for positive childbirth experience from WHO. Thank you.